I cannot believe that today I get to interview the god of dentistry, Gordon Christian. And I mean, seriously, in all seriousness, historically there was Pierre Fichard in France, then there was G.V. Black, and you're the third guy on that tier. I mean, you are
Well, thank
absolutely a
you.
legend. I'm sure you know it, but for me personally, Gordon, I always call you my dental father because when I got out of school, the mindset of the school is kind of like the Marine Corps, the boot camp. I mean, they did everything they
It's
could
worse.
to.
It's worse than that, Howard.
Oh yeah, they did everything to destroy your morale. And when I got out of dental school, I literally almost got on my hands and knees and kissed the ground when I walked out of that place. And then something happened to me. I went to Provo. I ended up going once a month for a year when I got out of school with Mike
Yes.
Totola, and we sat in the front row. And you were the first person that totally inspired me that dentistry was a science that you'll never ever be smart enough to completely figure out. It's bigger than life. It's all science, and you were the total inspiration of treating dentistry just like a hardcore science. And I mean, and I can't even count how many dentists tell me that you're their ultimate role model, their ultimate idol. And I'm so glad that you're doing this podcast with me today. So my first question to you, Gordon, straight out of the gate, is very simple. I got out of school in '87 in May, and then that October was Black Monday. I saw the recession, of 2000. We've been through several recessions. And when I got out of school, Orthodontic Centers of America was on the New York Stock Exchange, and there was a dozen on NASDAQ, and they all failed. So here I'm out now, 27 years. You've been at this game longer than I have. You've seen many recessions. You saw corporate dentistry rise to the New York Stock Exchange, NASDAQ collapse, and now you see it coming again with Heartland Dental having 600 offices with 2,000 dentists as employees, and Pacific Dental and Aspen. So my question to you is, what would you tell the 5,000 dental graduates who just walked out of dental school? A lot of people are thinking the sky is falling, that dentistry, we're all going to be working at Walgreens. So my question to you is, how does the sovereign profession of dentistry look? And Gordon, in 10 years, will half the dentists be working in chains like Walgreens and Heartland and Aspen and Pacific Dental?
I have some data on that, Howard, and you probably do too. Right now, 60% of American dentists are solo practitioners in their own little shop doing their own thing. I predict by 5 years we'll be down to 40%. By 10 years, we'll probably be down 30%. Is that bad? When I got out of dental school many years ago, I went into the military, and I learned far more in the military than I did in school. Net result was I had that experience before I went on to a couple of graduate schools. Now they get out of school and there's not much military because the federal government has honed down the military forces to the point where there's hardly anything going on. Bottom line is they have to go somewhere. They have $350,000 in debt, then where are they going to go? If they start their own practice, they're going to throw another 500,000 to $1 million on it. They can't do that. They can go into public health dentistry for a while. However, they can go into a major corporate. Just spoke recently, as you probably have, for Pacific. I've spoken for Heartland before. They're both trying very hard to make this a experience for these young dentists. Some of them stay a while and then leave and go into an associateship. Usually, one of my brother's grandchildren did that. He got with one of the biggies for a while and got some experience, good and bad, and then he left and went on into a practice where he's now very, very satisfied. But to answer your question, are we all going to be working for someone else? No, but the majority of the younger people will be. I don't see any way around that. There's just nowhere else to go. There's another complicating factor, and that is we have more dental schools than we need. We have 2 in the state of Utah. We don't need any. We're seeing schools pop up here and there and everywhere. The schools that are private, some of them doing a very fine job. but they're saturating the market to the degree that it's even worse for a young dentist who even intimates they want to start a small practice of their own. Bottom line, answer to the question, quick answer. Corporate is good, corporate is bad. And that depends on how you look at it, what time you are, or how long you've been out of school. But yes, many will be working for other people. I don't see
And
any other way.
and how many recessions have you seen since you graduated from dental school? And what did you think of this last recession? And do you think it's all changed, or do you think before you know it, America will just be adding 250,000 jobs a month again and another boom?
Just yesterday, I was looking at one of the doomsdayers videos, and there are those projecting even more recession. When we do a budget, as you probably do, you're an excellent businessman. As we do a budget, we look at not only what we owe, but what we have to take account for. Let's take Clinicians Report, our research group. We have thousands of people who have signed up for 1 year, 2 year, 3 years. But let's say a major recession came. Do we have enough money to pay back all of those post-dated subscriptions? And the answer is, yeah, we have 125%. Has the federal government got enough money to pay back entitlements? The answer is a vehement no. All they're looking at is their immediate debt, not their entitlements, not the Social Security, not the Medicare. They're looking at just what they obviously owe. What does that mean? Oh, there are innumerable more things that need to be accounted for. And there are the doomsdayers predicting another not little and short-term recession, but a major recession. I don't know whether I agree with that, but these are economists, and they're a lot smarter than I am. What did the last recession do to us? Now, practice-wise, it didn't do much to me because I've been around so long. People know me, and they wanted to stay. It took a terrible hit with Clinicians Report and with practical clinical courses. We have now recovered. Two-thirds of the charities, which Clinicians Report is a 501c3 charity, two-thirds of those charities in the state of Utah went bankrupt during that recession. Unbelievable. And the president at that time of the United States wanted to eliminate all charities, which I'm glad kind of died. Bottom line, I've been through at least one major and about 3 other minor recessions. In fact, my whole update course this year is oriented toward how do we overcome, to some degree, the recessionary mentality, which is I don't want to spend. I've directed my energies there.
So, Gordon, if you're coming out of school, $350,000 in student loans, and you work for a chain for a while, and you finally get a practice, to the dentists that have been out just like the last 10 years, there's a lot of very expensive machinery out there. A CBCT is $100,000. A CAD-CAM, Cerac or Sirona or E4D with Planmeca is $100,000. Lasers, I mean, some of these lasers like BioLaser, $40,000.
There's some 80,000 now. I just looked at one.
So let's go through those 3. A big capital purchase. A lot of guys would be listening saying, should I really double down and get another $350,000 in debt with a CBCT, a CAD-CAM, and a laser? Can you go through those one by one?
Yes. I have a whole course on technology. In fact, I've just done 6 videos for Shine on technology. We're doing a number of things in the technological area. There are probably 50 technologies out there. If they were to buy every one of them, they would have a good solid $1 million in debt or more. As we look at the more expensive ones, which you've enumerated, they are indeed valuable. I have had CAD-CAM now for 29 years. I don't use it a lot because I'm a prosthodontist, and so many of my procedures are multiple units, which I can do, and I'll be candid, somewhat faster with conventional methods than I can do with CAD-CAM. However, 9/10 of crowns in America are singles, and they can be done, as you know well, very adequately with CAD-CAM on a rudimentary basis. I have no problem there. So only 8% of dentists have CAD-CAM in their offices at this point. That's about 13,000 dentists, 8,000 of whom are using the device. So there are some of them sitting on Dental Town, there's some of them sitting on eBay. So some have made a purchase and then regretted it. Others have made a purchase and become a religious zealot over that concept. So one of the challenges I see in that arena is some of them have raised themselves to the boutique level of fee. I know they can do it at a very normal level and have a reasonable fee doing a crown with CAD-CAM. And that's one of the emphasis I use when I talk about that. This last ADA meeting in San Antonio weeks ago, I put Plan Scan and CEREC head to head. We had the best scanners they could find in each one of them, the best people. We scanned them and milled them right there, looked at them. They came out very equal. Then I had a conventional technique that we compared and we put them together and they came out darned equal. So I know they can be used in practice at a level that will be financially successful for the individual. Now let's go to cone beam. We've done more on cone beam, I think, than any other group because we've had the opportunity to have it ourselves for 12 years. And then one by one, we brought in test devices. I have CareStream in there right now, as compared with the purchase item we bought many years ago, which 12 years ago, which was the Planmeca. That device at this particular point, as you mentioned, is somewhere around $100,000. If you get all the bells and whistles, significantly more. Is that worthwhile? If they're doing implants placement, if they're doing third molar extraction, if they're doing endo, which they all are, they will eventually, I'll give them 5 years, not only cone beam, it will become standard of care. So I'm seeing that one as probably far more mandatory than the in-office milling concept. As far as laser, Rella, my dear wife, Dr. Rella, has been going practice to practice into offices that are laser dentists. She got the names from the Laser Academy nationally, and she's been going into these offices and doing microbiology and has some positive and some very negative things. Most of the claims made by most of the laser companies are only partially true or quite false. Can you sterilize a pocket? The answer is yes, for 1 millisecond. Then the sewer comes back in and no longer is it sterilized. Is it less painful? Yes, it's less painful. Do you have to use anesthetic? Not if they're dead, but if they're not dead, you must have anesthetic for a sizable number of them. Is it better than conventional methods? Yes and no, and I don't want to take the time to go through that sort of thing. But is it worth $40,000 to $80,000? The answer is a very moot point. It depends on who you are, what you are, how you advertise. Are you using it as a marketing tool? Are you using it for a scientific-based procedure that actually is better? So of those three, I would say cone beam is going to take the cake there because that's going to become standard of care very fast. The other two are somewhat effective. They're desirable for some and probably excessive for others.
So, Gordon, you talked about you originally bought Planmeca for a CBCT, and that was my first Pano machine was Planmeca,
Yes.
a huge company out of Helsinki, Finland. Right now, in the CAD-CAM market is probably 90% Sirona, and we just see that Planmeca bought a majority position at E4D out of Dallas. Do you in 10 years
Right.
do you think Sirona will still have 90% of the market, or do you see Planmeca being a competitor? Do you see other CAD-CAM companies coming out of Korea and Japan around the world?
You're on a really good roll. When I talk about digital periapical, they're like Fords and Chevys. They're very similar. When I talk about digital, obviously, cone beam, they're as different as night and day. You got SUVs and Porsches and trucks and so forth. Some will do a panoramic and a cone beam. Some won't do a panoramic and a cone beam without piecing the whole dang thing together. Others won't do a panoramic. Some have radiation, others have minimal radiation. Some can be made down to smaller sizes. Others, I don't like the sizes. They are as different as night and day. The most popular one out there right now, and this just changes routinely, is ICAD from China. The second most popular is Sirona, and a lot of that has been oriented toward the purchase of CEREC and the desirability of CEREC Connect. Third most popular is kind of a debatable thing, but it's Plan Mecca. However, I've given you U.S. data. If I go internationally, Vatek continues to be extremely high, if not number one. Vatek is South Korean. Carestream is right in that marketplace. Carestream is French. Sirona, obviously, is second, and that's German. Do we do anything in America? Not much. A lot of it's held up in FDA. A lot of it's held up with financial orientation. I wish we had more active American ingenuity, but we're held down politically fairly rapidly. You're going to see an up and down fluctuation of these cone beams till someone does everything. In other words, let's be able to have the sizes almost like a rheostat where I can turn it up or down. Let's have the ability to go facial lingually adequately with enough definition that I'm not bumbling around trying to see, is that really there or isn't it there? Many times we'll do a panoramic and do a subsequent cone beam, and we get different images on the same thing. The cone beam is, I'm going to put a prognostication on it that some would strongly disagree with, but it's my prerogative since I'm talking. I would say we're like an automobile in about 1950. We're partially there, but we're not there. With the digital periapical 3.4 millimeters thick, we need it down to a half a millimeter thick. Digital is one of the strongest problems we have in the whole profession. We can't detect initial carries. The devices are costing as much as a small car, $8, $9, $10, $11, $12,000. I can buy a phosphor plate for $40 and get the same image. That's something American dentists haven't figured out yet. You can do a phosphor plate and a CCD-CMOS on the same radiation device. One's $40, one's $10,000. We're stupid in America along that line. You were just in Australia a while ago. We found that, and when I was down there recently, Australians are using phosphor plates most of the time. We Americans are stuck on CCD and CMOS, which is fine for some things like implants, but not necessary for hygiene and other things. What am I seeing then? I'm seeing, will one cone beam dominate, which is your original question. One is right now. Will it stay there? I doubt it, although ICAD is great. Others are coming along, and now Plan Mecca's got into Plan Scan. Plan Scan's growing. In fact, I hear some rumors that they're selling even faster than CEREC right now. We will watch and see which one wins that race. It's like a horse race. They're in the race right now. Who's going to win? Nobody knows.
So you think Plan Mecca right now might be selling more CAD-CAM machines as of right now?
I've heard that rumor from various commercial people. We'll see. I don't know. But as without, why do we have 13,000 of them sold and only 8,000 of them being adequately used? I helped Plan Scan not too long ago go from a cart to a gamer computer. Rather than having a big miserable cart, fat running around in the operatory, they now have a gamer computer where you can sit it anywhere you want in the operatory, and it's wireless. So each one of those companies has got to look seriously at the other. Then you've got other companies that are milling now. You've got 3M that's now contracted with an organization to mill. You've got Carestream that's milling. So there are other comers on the market. The easier they make the scanner, the less expensive they make the whole concept. People are going to go there.
So, Gordon, a lot of people are wondering if combining a CBCT with a surgical guide, if it will lower the surgical skill necessary to place a single root form implant. Is this a holy grail? Do you see this to where someone who doesn't consider themselves a surgeon does not take out impacted wisdom teeth or partially impacted wisdom teeth. Could see a missing tooth, do a scan, have a lab make a surgical guide, and then just give a block, snap the surgical guide into place, and place a root form implant. Do you see this as like a holy grail of implantology?
You're on one of my, well, I don't know whether to call it a pet peeve or whether to call it just an observation. As you probably know, I run two levels of implant courses. One level, which is a 2-day course in Utah, is on small diameter implants, and it's on conventional diameter implants, 3 millimeters and up, on healthy people with good bone. That's level one. I can take a person who has minimal surgical experience and in days make them very adequately capable of placing an implant in a healthy person with good bone. No sinus lifts, no infraalveolar nerve transportations, just a simple placement of an implant. They all could parallel a crown prep. How much different is it to look at a ridge and say, go down the middle and don't miss the contiguous teeth? If 90% of implants are singles, which is the data, how hard is that? Not hard at all. 90%. Now, what's the next jump? The next jump is unhealthy people or people who have more peculiar health problems and going into sinus lifts, going into other kinds of surgical situations where it's more precarious. And that would be 10%. Some would estimate even up to 20% of implants are in those kind of situations, but certainly not everything. Now, that second course, we per days will get into that subject adequately. If someone has had a preliminary course in how to do smaller diameter being 8 to 2.9, and larger diameter, 3 millimeters and up. Do I think, now to answer your question, do I think that the surgical guide is going to save people? Having done implant surgery 35 years, which I have done, original course was from Brandemark himself, I would have to say when it came along, surgical guides, I thought, years ago they had a placement device for crown preps. You'll probably remember. Of course, it might have been a little before you, where you put this jig on a tooth and you paralleled it, and it took me longer to make the dang jig than to do the prep. I'd have 3 preps done before I made the jig. Is this the same thing? Maybe. I know my dental assistants laugh if I put a surgical guide on. What are you doing that for? I think for a neophyte, the surgical guide has major advantage. I think for a mature dentist, it has questionable value for the simple things. The more difficult things, yes. That's a personal opinion after quite a bit of experience.
And for a simple single placement in a healthy bone, are you laying a flap or are you doing a tissue punch?
Thank you. I was on a program, where was it? Chicago midwinter a while ago, where we had a couple of periodontists, an oral surgeon, I'm a prosthodontist, and some general dentists. And it was like talking religion. Everybody's right. You know, there is, if you're a Catholic, you're right. If you're Mormon, you're right. And everybody else is wrong. So everybody on that panel had a different opinion. Periodontist was hacking us a lot every time. The general dentists were back and forth. I do both. If the bone is particularly peculiar, let's say it's got a big hump on the occlusal and it comes down to a Mae West shape, I'm going to lay a flap. I can see it. On the other hand, if it's just a straight down tapered bone, for crying out loud, if I can't hit that, I'm hopeless. So the flap, yes, occasionally. With small diameter implants, 80% of them are placed with no flap at this particular point. You look at the situation, you use a ridge caliper, just a simple device, $200 from South and many others, and measure the ridge up and down facial lingual. Put your fingers on there and go right straight down the middle of the ridge with small diameter implants, avoiding that $400 to $1,000 surgical guide.
And Gordon, being a prosthodontist, 31 million Americans with no teeth, totally dentureless, they have dentures. Would you like small diameters, and would you prefer magnets as opposed to ball and ring to help give them some support, especially on the lower?
You're on a really good question, Howard. Having done small diameter implants since they were cleared by FDA, which was 1997, FDA cleared small diameter implants under 3 millimeters in diameter. As I said, they're 1.8 to 2.9. I've done hundreds and hundreds of them. We've lost a few. The course I'm giving this Thursday and Friday, I give the participants many reprints of scientific investigations that have been done over the years, showing about a 95% stability and acceptance of small diameter implants at 5 and more years. When they're placed in a situation such as 6 of them in the lower anterior, or 4 of them is normally what I do, 4 in the lower anterior with balls on them. That was the 3M concept. That's about 60% of the market right now, versus the new Zests coming out that have essentially a Zest component on the coronal portion. Very different, as you know. In fact, I'll be giving a paper at one of the implant meetings, ICOI, coming up in a few days, comparing 2 conventional diameter implants with 4 small diameter implants, both in the anterior, versus 2 and 2, in other words, 4 in the posterior then. And what's the best? Obviously, a 4-legged table is better than a 2-legged table. But I see the small diameter implant as a godsend to the person making under national average of money. National average for a family, as you undoubtedly know, is $51,000 a year for a family of 4. Now, can you take a family of 4 and lay 20 or 40,000 on them? Not without some sophisticated financial plan, and even then they don't want to do it. They will spend about 10% of their gross annual income on elective items, which we're talking about. So they'll go 10%. They're not going 90% or 100%. So I see 4 small diameter implants at $700 each, which is national average for a small, with a denture over it at $1,400. We're in the 10% of their full income. They'll do it. Will they go up to all on 4, which you know as well as I is an elite few making tons of money? No, they won't go there. They'll go for 2 or 4 small ones and $5K.
And are you just liking the ball and O-rings, or do you like magnets at all?
Well, if the bone is, and as you know, the bone is classified into various levels, and lower anterior being level 1, or the most dense bone. In that bone, 4 small diameter implants could have either housings on with locator type or ERA type abutments, but I still prefer the little rubber washers, which give you about 1 millimeter of movement potential. If I put a rigid one on there, yeah, it gives you 1/10 or 2/10 of a millimeter. I'd like 1 millimeter. So when they bite beefsteak over here, it'll lift a little bit better. So I both. If it's 4, yeah, I'll go with the locator ERA type, small or large diameter. If it's for posterior and anterior. If it's just 4 anterior, I tend to favor the balls.
So, Gordon, we've seen the price of implants. They used to be brand mark. Started in Sweden, and that's where the Nobel Peace Prize, and he started Nobel Biocare. And over the years, many other companies like Implants Direct have come much cheaper implants. Some people say titanium is titanium. Other people say, no, you need the patented design. And it was kind of confusing to everyone just a few weeks ago when the largest dental company in the world, Danaher, bought Nobel Biocare for $2 billion because they also own Implants Direct. So now they got a high cost and a low cost. So is titanium, or is a high cost brand mark of Mercedes, Porsche, and a low-cost Implant Direct more of Ford, Chevy?
I'm going to irritate every implant company right now, but I know you like that, so let's just do it. Some time ago, as Implant Direct started, you know all the history on that. Jerry Niznik was one of the rabble rousers and started Corvant and then myriad other brand names as things evolved through the years. Jerry, being a high-level innovator, did a very fine job in simulating or duplicating or mimicking the major brands, as you know. One day he flew through here in his corporate jet. It was early in the morning. It was a snowstorm, and he said, "Gordon, would you like to come with me down? I want to show you down in Southern California. It happened to be a weekend." I said, "Okay." So I leaped in the plane with him, and we flew to Southern California. And I said, "Jerry, I'd like to see such and such kind of implant. Uh, I know you'll understand this." By the time he'd shown me through the factory, the new implant was made. Now, we're talking about innovation, we're talking about creativity, we're talking about immediacy, we're talking about the ability to see an idea and jump rather than committee, council, presidency, financial advisors, board of trustees, et cetera, et cetera. Bottom line was, we brought the thing back. And we brought back some mimics of the abutments of the big boys. They were not only as good, some of them were better than those coming from the big boys. And that was a shock because I thought these will have to be Kmart specials. They weren't. The alloy is basically titanium, vanadium, and aluminum. And let's face it, they're all using about the same thing. You got a machinist standing there going $100, $100, $100, $100 on a big long piece of titanium alloy. And then you sandblast it, you pickle it in an acid, and you put some mysterious surface on it, and that becomes their patented integrating material. But then you look at the data internationally, and you see this patented brand is about the same as that patented brand in overall long-term longevity. To say, oh, this one's really better than that one, we're not seeing it. We did a survey just recently of general dentists to see what general dentists who were doing surgery were using. Implant Direct came out number one. Nobel was number two, and this is all data that could be readily observed on our research website, cliniciansreport.org. If they went in there, they could find this specific data. But what we found was a cheapo brand was number one. A secondary brand was Nobel, obviously, and then it went on down the line. And not too many of the more expensive ones got in there. We're teaching in our own implant courses medium level cost products, such as BioHorizons is definitely a mover. It's I don't know what place it is now. It's give or take fourth place in the implant world. I could be off one or two places, not much. We're seeing some come from South Korea. Hyosin, I've got in a course coming up the end of this week. A Korean company that has really stuck their neck out and done some nice things. A South Korean company, of course. But now back to your question: how do we have Walmart and one of the more expensive brands in the same company? And I've been on the internet with Niznik and others on that just recently. Well, how does that work? When you've got a low budget and a high budget, and they're looking pretty equal in the research. Why am I going high if low boy is still similar? They got to answer that. If they kill high boy, they're going to lose money. If they kill low boy, he's gone, and they'll come back and haunt him again. There's no question. Because let's face it, and this is going to irritate everybody, an implant done properly is an implant.
Yeah, that's interesting. Interesting purchase acquisition. I want to switch gears. We've been talking about more dentistry from engineering point of view.
Yes.
Digital dentistry engineering. Gordon, tell me if my perception is right or misled. It seems like I got out of school 27 years ago in 1987, and most of the fillings were amalgams. And they seem to last, 39 years. They seem to be bacterial. bacterial static. I think that the tin ions flying out of the amalgam, what have you. And then we had this cosmetic revolution where everyone's metal free, everybody's tooth colored, and the filling of choice was an inert plastic composite. And having seen these now out there for 20 years, it seems like they have a much shorter life, maybe as short as like 6 years. And the thing that I don't understand is whenever I see composite lectures, they talk about the wear rate all day long. I don't see fillings wearing down. They talk about the megapascals of bond strength. I don't see them falling out. I see dentistry as a biological problem of this bug, Streptococcus mutans, and it just goes to town, and you're just taking out decay with a number 4 round burn. It's oatmeal. So my question is dentistry kind of going the wrong way? Have we, in the last quarter century, have we gone from great fillings that didn't look pleasant or cosmetic, that lasted forever and were low cost, to now we have beautiful fillings, but they're not very antibacterial and they don't seem to last very long? How long would you say the average amalgams were lasting that we were placing in the late 80s versus the composites that we're placing now?
I have good data on it, and now we're going to irritate another segment.
All right, let's irritate everyone.
The bondodontist group is going to be irritated at me now. That's fine. We have good data on it internationally, and anyone listening to this can certainly do this observation themselves. Go to PubMed, or go to Google Scholar and put in whatever you want to know. And up will come papers. Some of you could even believe, not a lot of them. That's another one of my pet peeves, is peer review. But Howie's probably more peer-reviewed than some of the so-called peer-reviewed journals. If he says something wrong, if Howard says something wrong, he's going to have 10,000 townies on him in 4 seconds. Peer review usually has 3 people. Sometimes they even know what they're talking about. Most of the time, it's questionable. Going back to composites now. The data shows that a typical class 2 composite, GV black size or bigger, that would be, here's a cusp and here's a cusp. The tip of the cusp to the tip of the cusp is measurable. If 1/3 of that is cut away, that's a GV black level. If 1/3 is cut away of cusp tip to cusp tip distance, the tooth has lost 40% of its strength. And what do we see in 1/3 or bigger? We see a miserable 6 or 7 years of longevity in international data done with resin-based composite. Now that's kind of irrefutable information. On the other hand, if we look at amalgam of similar large size, the tooth is weakened. Does the bonding remain? Are you kidding? Anybody who's cut off a porcelain veneer on acid-etched enamel knows you can't get it off. You have to go in and cut it off. If you take the same veneer and say one of the teeth was sticking out, it's all dented, I can go and blow the dang thing off most of the time, or take a picker and pop it off the dentin. So what started out as a reasonable bond on the dentin with the hot, cold, hot, cold, hot, cold, hot, cold of foods, coffee, ice cream, the bond soon degenerates. That's a fact. So with amalgam, what do we see? It's not bonded. Well, you could bond it peripherally for a little while. We know that with various materials. We're seeing double or more the longevity. In other words, at least 14 years for a big amalgam. I was interested years ago. I helped start the University of Colorado and the University of Kentucky dental schools. And University of Colorado, my mentor who taught me a lot of things was the amalgam king of the earth. And that was Miles Markley. Some of you older guys listening will remember that name. Miles Markley had a father who was also an amalgam proponent. And Miles had slides of old Kodachrome going back to his father's practice. He had amalgams that had been in longer than the average lifespan of a patient. Lifespan. To say that these are somehow inferior is not even debatable. we looked at amalgam many years ago to detect how much this roughly 50% of constituency in the amalgam created apparent, and who knows whether it's all there, apparent health problems. You've all seen on the internet where they heat the amalgam and all the fumes come out of it. You heat your mouth that hot, you'll have fumes coming out every hole in your body and you'll die. So whether or not that's legitimate is highly debatable. But we found about 3%, and I could be off some, patients would have some sensitivity or allergenic potential with dental amalgam. To exclude it on that basis is undoubtedly foolish. However, World Health Organization has clearly stated it ought to be phased out. What does that mean, phased out? Does that mean at the end of the millennium or 9,000 years from now? What does it mean? That's a typical political weaselly statement. It'll Some dentists have already phased it out. Am I doing amalgam? No, I'm not. I'm a prosthodontist. I look at general dentists who are doing primarily smaller things usually. And right now, our latest survey showed 68% were doing amalgam some of the time. There was a sizable quantity, 20 to 30%, who were doing no amalgam. So it's still here in America. If I were in Scandinavia today, any one of the 5 countries, I could be booed right out of the room for even talking about amalgam, or Western Germany or Switzerland. Schools have not even taught it there for 15, 20 years. It's still a very debatable point. But yes, we have gone backwards in longevity. We have gone forwards in aesthetics. And I'm a past president of the Aesthetic Academy. I'm partially responsible for it. But very, very, let's say, straightforward about whether or not we have really done a wonderful job to throw plastic in everybody's mouth. Amalgam is slightly karyostatic. Composite is, you don't want to hear this, slightly karyogenic. And another thing.
Why is it slightly karyogenic?
Only because there is nothing in it that would kill people. In other words, you've got all the glass particles, you've got the silicon dioxide and various things, and you have an expansion contraction going on. You have a dentin bonding agent that doesn't really bond well on dentin, but does bond fairly well on enamel. And you've also got, these are peripheral points, you've also got the so-called bulk fill that's been kind of a joke. Because in bulk filling, 2/3 of the lights by actual in Toronto, Kano is a major avant-garde city, is up to date or more than any one of ours in America. What we're seeing there is that 2/3 of the lights were in their wavelength. No wonder class 2 resins are failing. Is it the material, or is it our lack of ability to cure it properly? Very, very strong controversial.
So based on 2 million dentists around the world doing fillings, so would you say then the average amalgam on average probably lasts on average twice as long as the average composite?
That would be probably conservative, yeah.
That would be conservative. And Gordon, do you see composites adding a karyostatic ingredient in the near future to where?
Well, think about it with me, Howard. If you put a karyostatic ingredient in a material that does not have water solubility, the karyostatic ingredient can't get out. We've tested sealants with fluoride in. And if you can visualize a sealant with fluoride particles in it, only the external particles can dissolve into saliva. Our research showed 6 weeks after the sealant had gone in and the external little spicules of fluoride on the outside had dissolved out, karyostatic activity was over. And any material that would be karyostatic, that would be composite, would have to be hydrophilic. And there are a couple, not used much in America. You'll remember Comprimers. Comprimers is a Comprimer Direct Extra is a good brand name. That is a hydrophilic resin. So the spit can come in, the spit can go out and drag out slight fluoride ion with it. any composite or composite-like material that's going to be cariostatic's got to have some ingress and outgo of fluids.
Now, your colleagues in Australia would say this is why they prefer glass ionomer on the walls and the base. So, do you think glass ionomer fillings, or what they call the sandwich technique, where they put a glass ionomer base and walls and a layer on the top? Do you think that's more cariostatic?
Yes, no question at all. Rella's research, Dr. Rella, my wife's research, Rella ran report well, and it was called CRA, Clinical Research Associate. She ran it for 27 years. Her research right now is showing, and I can't explain this at all, that the resin-modified glass ionomers, most popular is restorative materials, as you know as well as I, Fuji 2 LC or Riva from Australia, Riva high viscosity, very good material, Keytac Nano 3M, that those are releasing more fluoride than the pure glass ionomers, Fuji 9 and Chemrock and others. I can't understand that. She'll report it as soon as we've got enough data to feel totally legitimate, so I'm a little premature in even saying it. But both of them release a lot of fluoride, pure glass ionomers and resin-modified glass ionomers. So, as a reparative material on a crown margin that's failing, or in a very cariostatic kid who's in the pimply drug-taking age of 12 to 20, probably a lot of them should have fluoride-releasing materials either as an internal portion of the restoration or as the whole restoration.
So, and how much longer do you think, if a composite is lasting 6 to 7, an amalgam 14 plus minimum, where do you think the resin modified glass or the glass ionomer fillings would last?
There is no question that glass ionomer, not resin modified, that glass ionomer is not as aesthetically acceptable as composite. And for the nitpicking the bondodontist who wants to make these look exactly like a tooth, they're not going to be satisfied with that at all at this stage in its development. Resin modified glass ionomers, on the other hand, can have a reasonable acceptability aesthetically, but still they're not as aesthetically wonderful as one of the current good generations of resin-based composite. It's going to be a long time before that comes around.
So, Gordon, I want you to aim this discussion at a question we see on Dental Town all day long. I only have you for 12 more minutes. Gosh, it's been a fast hour. There's a lot of kids in dental school right now, maybe a third of the students that are thinking, okay, the economy's not that great. Is this a good time to come out, or should I go to specialty school? We have nine specialties. Could you go through?
Go ahead.
Could you go through the first of all? Could you go through the 9 specialties? And because you've been around a long time, and are any of these specialties look more promising than a general dentist?
I'm going to rapidly go through 17 of them.
17. There's only 9.
Anesthesiology failed as a specialty. In the past little while, I tried to help them make it a specialty and never made it. Dental anesthesiology is there, and some will go into it, and it's an area of need. Diagnosis and treatment planning is going to continue to grow rapidly because of the complex cases, particularly of the older generation now dying at 80. Endodontics is going absolutely nuts. Endodontics, because of the aged people, the pulps get smaller. It's going to go completely. That's a viable area for any young kid to get into if they want to. Aesthetic dentistry is in every dentistry except maybe endo, public health, and a few other things. But aesthetic dentistry, anybody that climbs on aesthetic dentistry is going to go nuts over the next little while. Implants are on fire. We've only 1% of Americans have had an implant. I get in countries where it would be multiples of that. We are so far behind on implant as a commercial hype and miscellaneous specialty turf battles that area really needs to be burst open. Occlusion is an area again, sitting there waiting. Somebody who's dumb enough to jump onto TMD and some of the occlusal things will undoubtedly find that area fertile if they can stand to be there. It's much like internal medicine, it would drive you nuts. As we look at operative dentistry, some say that's going to go away. Are they kidding? Rella, my wife, has found well over 100 organisms in dental caries. Back in 1880, we thought there were only 5 or 6, and dentists have stayed on that misguided judgment for all these years. You could kill all the strep mutans in the world, we'd still have gross dental caries. 100 different organisms or more. She hasn't even identified some of them. Oral and maxillofacial radiology is, you only have 500 of them. Any young kid that wants to jump in that and get in a community that doesn't have adequate, he's going to go crazy too with need. Oral and maxillofacial surgery is not going away. Oral and maxillofacial surgery will be there. Right now it's mostly general dentists. But it does take a little longer to do, and you have to get a Mickey Mouse MD if you want to really be accepted well in a hospital. So that's a negative. I have no idea why we have not kept dentistry in that same degree. A dentist knows far more than a pimple doctor or some others. It's amazing that we pulled ourselves away somehow. I had nothing to do with that. Oral pathology, somebody who hates people and wants to sit in a room and just look down a scope that's wide open and growing because of cancer and all of the various things we've got. Ortho's not going away. Big people marry little people. Little people marry big people. And the result is too big a teeth for little people and too little teeth for big people. That's going to be there. Pediatric dentistry, they kept telling me that was going to die. Did it die? No. It's bigger than ever. We had one move into this totally saturated area recently, and the guy was busy within days because whatever makes kids is not going away, and they're going to keep making kids, and therefore pretty wide open. Perio's dead. I'll pause and then let you think about it. Why is perio dead? What are periodontists doing right now? What do you think, Howard?
Implants.
They're doing implants. Well, you think about it. Implant, slit gum, maybe. Find bone, it's white. Make holes, screw, $2,000. You can do the same $2,000 and do perio and watch the teeth degenerate, get sensitive, mobile. You hear what I'm saying. What would you want to do? Perio is a dying area, and I make periodontists irritated when I say that, but it's a fact. Find a periodontist doing purely perio now. You're not. That's the only downer I'm going to give you, and I'm about done with this. What about practice management? Wow. Every school needs a mini MBA course. You know it better than I. They get out of school not able to even count, let alone count or write, let alone plan a financial management situation. Preventive dentistry, they think you can't make money in there. 10% of your patients have got overt caries going on routinely. Overt caries. All you got to do is say, would you like to slow that down or stop it? Who's going to say no? They jump on, get them a fluoride tray, stick some fluoride in it, open. It's a profit center, about 10% of any general practice, but they haven't awakened to that yet. Prosthodontics was supposed to die. When I was helping start University of Colorado, the then dean said, we don't need any prosthodontics by the year 2000. Oh my gosh. If we take now fixed, removable implant pros and the little appendage maxillofacial pros, that's 50% of general dentistry revenue. It was supposed to die. It tells you got to get your hands in there and work to figure out what the heck is going on. The public, you hate all clinical and you want to just sit in an office and plan other people to do it. Public health. There's 17 different things. We are vital. We're turned on. It's not going away. Take the organisms in perio and caries alone. We don't even know what they are, let alone how to fix them.
Gordon, a lot of people say that implants get periodontal disease too. It's very, very different than periodontal disease around teeth versus the perio inflammation on implants. Would you agree with that it's a totally different disease?
My theory there, and I would like to lead your listeners to a website. there are quite a few what am I going to say, legitimate websites out there. Many there would be considered to be holistic or semi-quacky. But there's one that looks pretty darn legitimate. It's a woman's name, Melissa, Melisa. Go there, any one of you, and look at what that website is saying about titanium or the other ingredients of the dental implant, vanadium, aluminum. You will find major allergic and sensitivity reactions. And what am I really saying? I've been in programs where they'll say, look at this peri-implantitis. Then you look at the implant in the bone. It's perfect. What's making that gum red? What's making it look like peri-implantitis? I have a very strong feeling is metal sensitivity, just the same as you see around a nickel chrome crown. So,
and that just Melissa,
correct in what you're saying.
That's just Melissa.com, just the name Melissa.com.
Just put in Melissa and then any other adjective like metal allergy. I have been into it very recently, but
Okay.
and then just go to the metal. They'll have listed the metals there.
I've only got you for 5 minutes. How you doing on time?
I'm doing fine. Yeah.
Okay.
Cool.
Gordon, oral cancer. When I got out of school 25 years ago, just the people who smoke and drank for 20, 30, 40 years. Now everyone's talking about HPV and oral pharyngeal cancer. What are your thoughts on that? Do you see this as a growing epidemic, or do you see it more? Do you think this is a large scale problem? Are you recommending your young patients to get an HPV vaccine?
Yeah, we definitely need to rub the two together, and we're studying right now several solutions, devices, techniques to put the two together and try to determine if there is in that particular body we're specifically looking at a problem with either. Oral surgeons tend to get whipped up when I talk about fluorescent testing of people for cancer detection. As you know, you've got the scrape it off business, which was false negative, false positive, but you've got the dyes where you splattered it all over everybody and got their shirt dirty. We've got the fluorescent. Of the 4 stages of oral cancer, 2 of them I want to find immediately. That's where there's still an epithelium, and the basal portion has minor involvement, and the fluorescent lights show that. The other 2, you're actually seeing a lesion, or one we're testing right now where you spit in a bucket and they test DNA to see if there's something going on there in the mouth. I have to see something to be suspicious, and it costs a couple $100 to do that. I'd like to shine a light in there, and I'd like to see a gray area and say, come back in 2 weeks. If it's still there, we'll decide what to do then. They're back in 2 weeks. I'm still seeing a gray area. I'm going to wait 2 more weeks, at which you get a slit and a regular biopsy. Now I'm catching it on the stage 1 and 2, not 3 and 4. By the time they're on stage 3 and 4, you can't really fix that. They're going to lose half their face. They're going to lose a significant chunk of bone. I feel very strongly that should be a dentist or dental hygienist, readily detectable situation, but because it's a low revenue producer, it has not been a big thing, as you know. Dentists say, well, I'm not going to do that. It doesn't bring me any revenue. They should be doing it just like they're doing hygiene. Hygiene brings slight revenue. You can easily make this bring slight revenue. Yes, cancer is.
What brand name of a light do you like?
Well, the Bell Scope is the most popular. However, Shine is selling one called Identify that is also excellent. Anyone that's flashing the fluorescent light in there is going to show gray areas wherever there's tissue challenge. There are some false negatives, false positives, because if you bit your tongue and shine the light on there, it would be gray. That's why you wait 2 weeks and wait another 2 weeks.
But do you see oral cancer increasing because of HPV?
I don't know whether I could even say that without just really guessing. It appears yes, but who knows?
Well, my question is Gordon, why the data says that the Americans see a dentist twice for every time they see a physician.
Yes.
I go to Walgreens, a pharmacist can give a flu vaccine. I
Right.
can't. And HPV is associated with oral and pharyngeal cancer, and I'm not even allowed to give an HPV vaccination or a flu shot. How come I'm a doctor of dentistry and I can't
Right.
give grandma and grandpa a flu shot or a child an HPV vaccine?
We need a lot of things nationally in our major organization. I'm very supportive of the ADA. We need a committee, a council, or whatever the heck it takes to sit down and say, look, dentists get the same dang education as you boys when you were talking to a physician. Dentists had too much to teach, so they split us off. In the meantime, we have the same education you do. Use us. Use us. I would just wish we were back in that, except for the political implications and the challenges we're now seeing with the so-called Affordable Care Act. If it weren't for that, I'd say I would be vehemently wanting to reintegrate with that group. We should have the same prestige, the same acceptance as any typical physician. The only thing we've lacked is bumbling around in the last year or two watching somebody else do something. But as far as actually treating people, giving injections, doing antibiotics, analgesics, we're far ahead of the typical physician. We just need some political clout there.
I only have you for one more minute, but I got two last quick questions. Florida passed a law that lets foreign trained dentists from around the world be a hygienist if they pass the hygiene boards.
Right.
Would that be a good idea for all 50 states, or is that a bad idea?
We are so oversaturated in dentists and right now, but we're more oversaturated in hygienists. We have 5 schools in this little state in which I live. 5 schools. Do we need 5? No. We might need 2. Do we need to saturate it with foreign people? Take a look at California with dentists. They've opened the doors. When I was down there on a Mormon mission some time ago, I could talk to the Indian Dental Society, the Hispanic, the Chinese, the Korean, but if you tried to get them all together, they weren't there. Too many dentists. I'm a little questioning whether that should be done.
And last question, we talked about, is dentistry going backwards with fillings from long lasting to shorter lasting? Water fluoridation. My gosh, Gordon, it seems like every time you turn around, another town is taking out. We still have 30% of American towns without water fluoridation. What do you think of community water fluoridation?
Well, you know just as well as what are they drinking right now? They're drinking, some of it has fluoride in it, some of it doesn't have fluoride in it. My wife won't drink tap water anymore. She doesn't like the taste of it. It has nothing to do with purities, just doesn't like the taste of it. It's not as valuable as it was before, but it hits the people who need it the most. They're the poverty-stricken people living in areas where they're not buying bottled water. They're drinking it right out of the tap. It's still highly desirable. And I think you know as well as I, or better, that the do-gooders who are trying to get it out are usually in that fringy area of health, what am I going to say, holistic medicine, which is good and bad. I would say that fluoridated water, and I've been on it ever since I've been in puberty, fluoridated water is still very desirable for the very people who need it, the low-income people.
Well, Gordon, we are out of time, and I just want to say thank you for being my number one role model and idol, and I can say that on behalf of literally probably 500,000 dentists around the world. I mean, it's you're a living legend. It's just great to see you. Thank you for all you've done for dentistry.
Thank you. I'm going to lead them to 2 websites if they want to get more information about what we do. That's Paul, like practical clinical courses, pccdental.com. And clinicians, just like it sounds, cliniciansreport.org. And that would give many information about what we're doing. Thanks, Howard. You too have done an unbelievable job to stir the profession up and get them thinking again. And by the way, you look good. You lost half your body, didn't you? That's great. Keep losing.
All right, buddy. Tell your lovely wife I said hello.
Thank you.
Okay, bye-bye.